Welcome to the deep dive.
Great to be here.
Today we're tackling a really interesting condition, Kartagener's syndrome. You might also hear it called Primary Ciliary Dyskinesia, PCD for short.
Right.
We've basically gone through the available info to pull out the key things you need to know about this rare genetic disorder.
Yep. Our aim is really to give you a clear, concise understanding what it is, the causes, the main features, so it sticks in your mind.
Exactly. Make it easy to recall the essentials. Think of it as your high-yield guide.
Precisely. The must-knows, basically.
All right, let's jump straight in. What defines Kartagener's syndrome? What are the absolute core elements?
Okay, so the first thing is that it's rare, and it's inherited in an autosomal recessive way. Genetic.
Autosomal recessive.
But the real calling card is that triad.
Yeah.
First, situs inversus. So imagine your internal organs flipped, like a mirror image. Heart on the right, liver on the left.
Way.
That's the first part, and it's pretty striking. Second, you get abnormal frontal sinuses. And this often means chronic sinusitis and bronchiectasis, those nasty long-term lung changes.
Okay.
And the third part, the underlying issue, primary ciliary dyskinesia. Basically, the cilia, those tiny little hairs lining your airways, they just don't function correctly.
Well, cilia. All right, like tiny sweepers in our airways. What goes wrong when they're not doing their job?
Well, they're crucial for clearing mucus, getting rid of debris. Often, the problem is a defect in what are called dynein arms. Think of them as the motors making the cilia beat. But it's not always that. Sometimes the structure looks okay under the microscope, but they just don't move properly.
Right.
So diagnosis really has to look at structure and function.
And the consequence of them failing.
Mucus builds up, it can't get cleared. This leads to repeated respiratory infections, inflammation, and eventually damage to the airways.
Makes sense. Now, you mentioned the triad, but does everyone with PCD have all three parts?
That's a really important point. No, they don't. Only about half of people with PCD actually have the full Kartagener's triad, including the situs inversus.
Okay, good distinction.
And sometimes you might see links to other things too, like retinitis pigmentosa, affecting the eyes, or even hearing loss.
That situs inversus, the reversed organs, it's so distinct. How can faulty cilia cause that?
Yeah, it's fascinating. The current thinking is that normal cilia function is actually essential way back in embryonic development.
Ah, right at the beginning.
Exactly. They help establish the body's correct left-right asymmetry. If the cilia aren't working then, that whole process can get randomized or even flipped, leading to the mirrored organs.
So let's trace it back further. What's the root cause of these cilia not working, the genetics?
It goes back to that autosomal recessive inheritance pattern. You need to inherit a faulty copy of a relevant gene from both parents.
Okay.
These mutations mess with proteins needed to build functional cilia or make them move correctly. So the beating motion is disrupted, mucusclearance fails, and you get those recurrent infections.
And who's most at risk of inheriting this?
Well, the main risk factor is having a family history of Kartagener's or PCD.
Naturally.
Also, parental consanguinity, if the parents are related, like cousins, that increases the chance that they might both carry the same rare recessive gene mutation.
Right. Okay. So we've got the definition, the genetics. Let's talk pathophysiology. How does this faulty cilia problem cascade through the body?
It really centers on that impaired ciliary motility. No effective sweeping motion means mucus and inhaled particles just sit there.
Stagnant.
Exactly. And that becomes a perfect breeding ground for bacteria. So you get recurrent infections, chronic inflammation.
And that inflammation causes damage over time.
Precisely. That's what leads to bronchiectasis, the widening and scarring of the airways, and the chronic sinusitis. The situs inversus, remember, is more of a developmental consequence from that early stage.
And you mentioned the dynein arms earlier.
Yes. Defects in those dynein arms are a very common reason for the cilia being immodal or dysmodal. They're just structurally unable to generate the proper movement.
Okay. So if someone comes in with these sorts of symptoms, chronic cough, sinus issues, maybe even the organ reversal, what else could be going on? What's a differential diagnosis?
That's crucial because you need to rule out other possibilities. It's a broad list, actually.
I bet.
You'd think about common things first, like allergies, allergic rhinitis, maybe allergic bronchopulmonary aspergillosis, or even just enlarged adenoids, especially in kids.
Right.
Then anything causing bronchial obstruction could be acquired, like a foreign body, a tumor, maybe COPD, or congenital things like bronchomalacia, floppy airways. Immunodeficiency states are important too, conditions where the immune system isn't working properly, leading to lots of infections, like issues with IgG or IgA antibodies. and other disorders affecting mucus clearance specifically. So other types of cilia problems, cystic fibrosis is a big one to differentiate.
Oh, yes, yeah.
And syndrome too. And there's a miscellaneous category, things like alpha-1 antitrypsin deficiency, chronic aspiration problems, even certain types of lung disease or malignancies.
So quite a few mimics.
Definitely. It really underlines the need for a thorough workup to pinpoint Kartagener's.
Speaking of pinpointing it, how common is this condition? What are the numbers like, say, in the UK?
It's considered rare. Estimates vary. It may be somewhere between 1 in 15,000 and 1 in 30,000 people in the UK.
Okay, so definitely not common.
No. And because it's autosomal recessive, it can pop up in any ethnic background. Worldwide incidence is often quoted around 1 in 32,000 births. And again, higher rates are seen where consanguineous marriage is more common.
Got it. So let's talk about the clinical picture. What signs and symptoms would actually make you suspect Kartagener's?
You're looking for a pattern, usually starting early in life. Think persistent chronic sinusitis, recurrent chest infections, bronchitis, pneumonia over and over.
Right.
A chronic, often productive cough, sometimes with quite thick, purulent sputum, constant nasal congestion, maybe a poor sense of smell.
Okay.
And then, if you discover they also have situs inversus Kartagener, that's a huge clue, though remember, it's only about half the cases.
Still, a major flag if it's there.
Absolutely. Other things that often come up are infertility. Men often have amodal sperm, and women can have reduced fertility due to issues with cilia in the fallopian tubes, and sometimes hearing loss, often conductive due to middle ear problems.
So key features to keep an eye out for are dextrocardia or situs inversus, the bronchiectasis, the recurrent sinusitis, and maybe subfertility.
Exactly. And digging into the history, maybe there was respiratory distress right after birth, or chronic runny nose, poor smell, constant ear infection since childhood, association with COPD or bronchiectasis later, male infertility. These are all big pointers.
And on examination, what might you find?
Well, you might detect the dextrocardia heart sounds on the right, maybe signs related to situs in versus like issues with the spleen, potentially. Looking in the nose, you might see polyps or signs of chronic rhinitis, sometimes corneal abnormalities, signs of conductive deafness from the ear issues. And in some long-standing cases, you might see clubbing of the fingers and toes.
That's a lot of potential clues. So how do doctors confirm the diagnosis? What investigations are actually done?
It's usually a combination approach. A chest X-ray is often a starting point. It might show the dextrocardia, maybe signs of lung changes like hyperinflation or thickening.
Okay.
A high-resolution CT scan, an HRCT, is really important for confirming bronchiectasis. And looking closely at the sinuses, you often see poor development or aeration, sometimes absent frontal sinuses.
Right. The CT gives a better picture.
Definitely. Then, for the cilia themselves, the gold standard is transmission electron microscopy. This involves taking a small biopsy, usually from the nasal lining or sometimes the trachea, ideally when the patient isn't acutely infected.
And that lets you see the structure.
Exactly. You can look for those missing dynein arms, assess the structure, and sometimes specialized labs can even analyze the beat frequency and pattern. It helps differentiate primary ciliary problems from secondary ones caused by infection. In postpubertal males, a semen analysis is key. It will typically show immotile or poorly motile sperm with abnormal structure. There's also a test measuring nasal nitric oxide levels are usually very low in PCD because the sinuses aren't clearing properly. It's a good non-invasive screening test.
Nitric oxide. Interesting.
Yeah. Pulmonary function tests, like spirometry, often show an obstructive pattern, maybe hyperinflation, and sometimes tissue from other procedures, like tonsillectomies in kids, can be used for analysis. Increasingly, genetic testing is becoming central to confirm the diagnosis by finding the specific gene mutations.
So multiple angles to confirm it. Once it is confirmed, how is Kartagener's managed, say, in the UK system?
Management is really about supportive care and tackling the consequences. Aggressive treatment of respiratory infections is key, often with oral or sometimes IV antibiotics, targeting common bugs like H. influenzae and Staph aureus.
Makes sense given the infection risk.
Absolutely. For the chronic lung disease, the bronchiectasis, standard care involves inhaled bronchodilators, drugs to thin mucus called mucolytics, and really importantly, regular chest physiotherapy to help clear secretions.
Airway clearance techniques.
Exactly. Sometimes things like nebulized hypertonic saline or other agents like DNase are considered to help clear mucus, although the evidence for their effectiveness in PCD specifically isn't always crystal clear. Vaccinations, flu jab, pneumococcal vaccine are strongly recommended.
What about the ear and sinus issues?
For recurrent ear infections and hearing loss, Grommets tympanostomy tubes might be inserted, sometimes needing repeat procedures. Chronic ear discharge needs careful management. For sinus problems, sometimes endoscopic sinus surgery, like creating a nasal antral window, can provide temporary relief.
Any more drastic surgical options?
In very select cases, with severe localized bronchiectasis, removing a lobe of the lung, a lobectomy, might be considered. And in end-stage lung disease, lung or even heart-lung transplantation has been attempted, with some success, but it's obviously a major undertaking.
A last resort, really. So what's the overall outlook? What's the prognosis for someone with Kartagener's?
It's quite variable, honestly. It really depends on the severity of the respiratory disease and if there are other complications.
Right.
But early diagnosis and diligent proactive management, treating infections promptly, consistent airway clearance definitely improves outcomes and quality of life. It is a lifelong condition requiring ongoing specialist care.
But treatments are improving.
Yes, advances in managing bronchiectasis and infections mean the prognosis and lifespan for people with PCD, including Kartagener's, are generally much better than they used to be. Still, having established bronchiectasis does impact the long-term picture.
And what are the main complications to be aware of throughout life?
The big ones stem from the underlying problem. Chronic respiratory infections, recurrent sinusitis, the irreversible lung damage of bronchiectasis, hearing loss is common. Infertility is a major issue for many, and in severe cases, progression to respiratory failure is the ultimate concern.
So constant vigilance and management are key.
Absolutely. Minimizing those complications is the main goal of ongoing care.
This has been incredibly helpful, really breaking down Kartagener's syndrome. So to quickly recap, it's that rare genetic disorder, remember the triad, situs, inversus, sinus bronchiectasis issues, and the core problem of faulty cilia.
Yep, the cilia dysfunction drives the respiratory problems.
Diagnosis involves clinical picture, imaging, specialized ciliary tests, and genetics. Management is supportive, focusing on infection control and airway clearance.
That's the essence of it.
And it's just fascinating, isn't it, how something so tiny, those microscopic cilia, can have such profound body-wide effects. Really shows how interconnected everything is.
It really does. A perfect example of micro-level function impacting macro-level health.
Well, if you listening want to consolidate this and explore more topics for exam prep, definitely check out pastthemsra.com and also freemsra.com for resources.
Good resources there.
Thanks so much for joining us on The Deep Dive.